Thank you, Dr. Morales, for your kind introduction. Good morning, dear colleagues. So my task this morning will be to talk about acute pancreatitis. We will learn how imaging should be scheduled for patients with acute pancreatitis. And I will try to make you more familiar with the new terminology that has been proposed in the revised Atlanta classification. So the first part of my speech will be mainly dedicated to those new terminology and new definitions, but first the background. As you may know, the original Atlanta classification from '92 is clearly outdated. There were confusing definitions and a lack of intervals of agreement when using terms for fluid collection in the pancreatic and peripancreatic areas. So during the period 2007 and 2012, an international web-based consultation took place and proposed new concepts and definitions for acute pancreatitis. So grossly, you just have to know that acute pancreatitis is differentiated in two clinical phases. An early phase, mainly in the first week, and a late phase after the first week. Because acute pancreatitis is a dynamic and evolving process, you will find that there are two mortality peaks. The biggest one in the early phase, of course, due to organ failure, and we will stress that point, and a second mortality peak due to local complications. First definition, diagnosis of acute pancreatitis. You need two of the following three features to accurately define an acute pancreatitis. First, an abdominal pain, which is an acute onset, severe, and persistent epigastric pain. Second feature, an increase of serum lipase activity 3 times above the upper limit of the normal. And third features, of course, characteristic findings on contrast and NCT mainly, but also the consensus paper authorized MRI, of course, and ultrasound to evaluate characteristic findings of acute pancreatitis on imaging studies. If abdominal pain and serum lipase increased activity are present, CT is clearly not required for diagnosis in the ER or on admission at the hospital. And if the acute pancreatitis is not a severe one, CT will not be required at all, at least in theory. Definition of onset of acute pancreatitis. It is clearly the time of onset of abdominal pain and not the time of admission to the hospital. And it's one of the main concerns regarding the onset of acute pancreatitis, and to clearly choose the time to schedule CT examination, you have to note or to ask to the patient or to the clinician the time interval between onset of abdominal pain and time of admission to the hospital, which could be quite different, of course. The former classification of Atlanta '92 differentiates 3 types of pancreatitis: interstitial pancreatitis and necrotizing pancreatitis, either sterile or infected. The new classification of Atlanta 2012, you have only 2 types of pancreatitis: interstitial idiopathic pancreatitis and necrotizing pancreatitis, which is more clear. Both types may be either sterile or infected. Of course, infection of interstitial idiopathic pancreatitis is quite a rare situation. So interstitial idiopathic pancreatitis will be seen with inflammatory edema that will cause diffuse or focal enlargement of the pancreatic gland, the so-called type B of the Balthazar classification at CT, and in most cases, it will result in the first week. On the other hand, necrotizing pancreatitis, which is much more less common, will cause impairment of pancreatic perfusion, and that lack of pancreatic perfusion will cause necrosis. And that necrosis can be located in the pancreatic parenchyma, in the peripancreatic tissue, or in many cases in both. And we will emphasize that important point because there are many confusion about location of necrosis and the term that could be chosen for that. That necrotizing pancreatitis will evolve for several days, and that means that an early contrast-tendency CT may clearly underestimate the extent of the disease, and for that reason, early CT is not warranted in necrotizing pancreatitis. What about infected pancreatitis? Of course, both pancreatic and peripancreatic necrosis may remain sterile or become infected, but there is no absolute correlation between the extent of necrosis and the risk of infection. And once again, in the first week, infected necrosis is a rare condition. So let's go back to the two phases. Those phases are overlapping, of course, but the early phase is more or less during the first week of disease. During that first week of disease, the host response to the pancreatic injury, the so-called systematic inflammatory response syndrome, will be the main cause for severity, and the severity at that time will be related to the presence and duration of organ failure. And we will define organ failure in the next slide. At that time, the early phase, we do not encounter any local complications usually. And those local complications are not predominant determinant for severity. And once again, extent of the morphologic changes are not proportional to the severity of organ failure. So there is clearly no need to evaluate the morphological changes in the first week of disease. So looking very accurately to the reference paper published in Gut 2013, which is the reference paper from the International Working Group, there is no clear recommendation for scheduling CT, but you will find 72 hours at least. So I know that in real life, we will discuss that point, it's clearly difficult, but no CT before 72 hours. And some authors advocate for more than that after the first week. So what is organ failure? Organ failure needs assessment of respiratory, renal with serum creatinine, and cardiovascular with systolic blood pressure evaluation. A score of 2 or more in any of these three systems will define the presence of organ failure. You can have single organ failure or multiple organ failure. And what will be important is to have transient or persistent organ failure. Let's move to the late phase. The late phase grossly begins after the first week. And at that time, the severity will be related to either persistent organ failure over 48 hours and presence of local complications. And local complications that will be defined in the next slides will clearly be a need for morphological evaluation and clearly for contrast and CT. So there is, at that late phase, a need clearly for both clinical and morphological criteria. Let's define local complications. Local complications are more or less presence of pancreatic and peripancreatic collections. And we have now specific terminology for those morphologic features that will be detailed in the next slides. And other complications, of course, are possible, including portal thrombosis, colonic necrosis, or pancreatic pseudoaneurysm, but we will not detail them for time constraints. Those local complications should be suspected in case of recurrence of abdominal pain, if you have a secondary increase in serum amylase level, and also if you have increased organ dysfunction or increase in CRP, fever, or leukocytosis, that are related to a sepsis condition. There are three types of acute pancreatitis in terms of severity. Mild acute pancreatitis is the less severe one. In that case, you will have no organ failure at all and no local or systemic complications. This is by far the much more frequent type, and in such a situation, the mortality is very, very close from zero. The second severity grade is moderately severe acute pancreatitis. Moderately severe acute pancreatitis is defined by presence of transient organ failure that resolve less, sorry for that mistake, less than 48 hours, and or local or systemic complications without persistent organ failure. Systemic complication meaning exacerbation of comorbidities, patient with heart failure or chronic lung disease, for example. And the third grade of severity, the most important one, severe acute pancreatitis, is defined by persistent organ failure after more than 48 hours. That could be single or multiple, and in that case, mortality may be up to 50%. We have two types of collections in acute pancreatitis. Collection composed of fluid alone and collection composed partly with solid components and mainly with fluid and solid components. So know the terminology. If the collections are composed with fluid alone, and if you are in the first 4 weeks, you should call that collection acute peripancreatic fluid collection, APFC. So remember that term, it's a new term, APFC, for acute peripancreatic fluid collection in the first 4 weeks with fluid alone. And of course, it's related to the type of interstitial edematous pancreatitis. After 4 weeks, in interstitial edematous pancreatitis, those fluid collection may become a pancreatic pseudocyst. Regarding collection with solid components, in the first 4 weeks, they should be called acute necrotic collection, ANC. And after 4 weeks, those necrotic collections have a new term, which is walled-off necrosis 1. Let's detail the CT appearance and the imaging appearance of those 4 types of collections. First, APFC. APFC are supposed to be adjacent to the pancreas, to be seen with fluid density and with homogeneous content, and they are confined by normal fascial planes, in particular by the pararenal anterior fascia. They have no well-defined wall, which is important, and they are extrapancreatic only. If you see lack of enhancement inside the pancreatic parenchyma, of course, it's not APFC. It will be clearly ANC, acute necrotic collection. So it's in the first 4 weeks, and it's related to interstitial edematous pancreatitis. Most of the APFC will remain sterile, and most of them will resolve spontaneously. Only a very few of them will evolve to a pancreatic pseudocyst. So if it persists after 4 weeks, it will give a pseudocyst, but clearly it's a rare situation. This is an example of interstitial edematous pancreatitis in a 52-year-old female. Here you have something which clearly looks like APFC. It's strictly around the pancreas. It's homogeneous. It's a fluid density. It's confined to the normal planes. And the same patient 2 weeks later evolves to normal CT appearance. What about pancreatic pseudocysts? They are defined as a fluid collection in the peripancreatic tissues with well-circumscribed appearance. They are round or oval-shaped with a homogeneous low attenuation, and they have a well-defined enhancing wall. there is no solid component. Of course, CT is not the best examination to be sure that there is no solid component, and of course, MRI or US are by far much more accurate in detecting solid component in a fluid-like collection at CT. So pancreatic pseudocyst should be, that term should be used only after 4 weeks of evolution. It looks like a pancreatic pseudocyst here at CT. It's round shaped. You have an enhancing wall. It looks homogeneous, but in the same patient, you can see here in the pancreatic body or around the pancreatic body something which is much more heterogeneous. Okay, in such a situation, of course, I think MRI is clearly a solving problem technique because, of course, it's not a pseudocyst. It's a necrotic collection with solid component, which is clearly seen here. And here it looks also like a pseudocyst, but here also there are some solid components inside the lesion. So it's a acute necrotic collection. Some pseudocysts may appear in a very bizarre situation, including the mediastinum, as you know. And we also have to know that in pancreatic pseudocysts, the fluid inside the cyst will have increased amylase activity. That means that increased amylase activity is related to a disruption of the pancreatic duct with communication between the cyst and the pancreatic ducts. It may clearly be important to assess that condition and to make a diagnosis of duct rupture because it could influence patient's management. Contrast and NCT, of course, may be able to detect such a pancreatic disruption, but I have to admit that I took that pictures from a CT that I performed more than 10 years ago to be able to show you such a nice picture. Of course, CT in case of non-dilated duct is not the best technique to make the diagnosis of rupture. MR by far is much, much more accurate. So if you have to assess the ducts in acute pancreatitis, and you should assess the duct, even though the new Atlanta classification does not ask it in a regular situation for every patient, you should use MR. And that's that nice example from the paper of Celso in Radiographics 10 years ago, perfectly show that disruption and communication between the main pancreatic duct using secretin with that pseudocyst that is clearly shown here on the HASTE sequence. So, of course, MRCP for assessment of the duct and disruption. What about acute necrotic collection? This is a term you should use in the first 4 weeks in case of pancreatic necrosis, and it's located in the pancreatic parenchyma and or the peripancreatic tissues. It will contain both fluid and solid material, and it will look clearly heterogeneous with variably lobulated peripheral appearance, but it's not encapsulated in the early 4 weeks. It may be sterile or becomes infected, and to be clear, in the first week, and mainly if you do an early CT before 72 hours, it will be clearly difficult to distinguish between APFC and ANC. First example here, you have something that looks like APFC. It's, in my opinion, quite homogeneous, low density, around the pancreas. It could be acute peripancreatic fluid collection, but it could be also acute necrotic collection. So you have to wait for the next CT. It's day 3, and here it's day 8. At day 8, no doubt, it is not APFC. It's an acute necrotic collection. It's a necrotizing pancreatitis. And day 20, it's an infected necrotizing pancreatitis due to the presence of gas here. So acute necrotic collection could be in both pancreatic and peripancreatic necrosis. This is the most common situation, accounting for around 75 to 80% of the cases, according to the paper from Tony. So both pancreatic, as you can see here, and peripancreatic, as you can see here, necrosis. Another example with both intrapancreatic and extrapancreatic low dense formation corresponding to acute necrotic collections. Second situation, which is very, very rare, the pancreatic necrosis is only in pancreatic parenchyma alone, with a lack of parenchyma enhancement. And this is the case at day 5, I took from the paper from Tony, with only intrapancreatic necrosis without peripancreatic necrosis, which once again is very rare. Another example, a personal example here in the pancreatic head, which is not a tumor but clearly a lack of enhancement related to pancreatic necrosis. And a third situation, which is very important to emphasize because sometimes it creates still confusion. You could have acute necrotic collection in necrotizing pancreatitis with only peripancreatic necrosis. It's not so rare. It accounts for around 20% of the situation. And it has a better prognosis compared to necrosis present in both pancreatic parenchyma and peripancreatic area. And here it is an example where there is normal enhancement of the pancreas, but a large amount of fluid. But I will detail that example in a few slides. The fourth and last terms, walled-off necrosis. The previously sequestration, necroma, or organized pancreatic necrosis, never use that term again. It's walled-off necrosis, 1. So it's only after 4 weeks. It's inside the pancreatic parenchyma and or outside of the pancreatic parenchyma. It will contain necrotic material, so liquefied and non-liquefied solid components. It will appear heterogeneous, mainly with fat-containing areas, and it will be variably lobulated, but the main point, it is very well encapsulated with an enhancing pseudowall. And this is the main difference with acute necrotic collection. So it can sterile or become infected, of course, and walled-off necrosis, because it will contain necrotic material, that diagnosis will have influence of the management of the patients, because he will in many cases, when it's a huge in volume like that, it will need drainage, even though it is not infected. So back to the case where there is only peripancreatic necrosis. As you can see here, the pancreatic parenchyma is clearly seen everywhere, and there is no defect of enhancement. There is no intrapancreatic necrosis. But around the pancreas, clearly, it's not APFC. It's acute necrotic collection, and after 4 weeks, clearly, it becomes walled-off necrosis. So it's peripancreatic necrosis alone. And after 12 weeks, that patient recovers after 5 months of hospitalization with successful drainage. What about the complications of acute pancreatitis? Of course, infection may concern all collections, and presence of gas is the main CT findings indicating infection. Of course, fine needle aspiration or drainage also may give you the diagnosis of infected pancreatitis. So infection may concern all types of collections, and in that case here, you can see intrapancreatic collections, A and C, with clearly gas in this collection in the head of the pancreas, and also small bubble of gas here. This is clearly infected acute necrotic collections. Portal thrombosis, of course, is a common situation in acute pancreatitis. It's not only for splenic and superior mesenteric vein, but also it can be seen in intrahepatic portal veins, like here. For the last 2 minutes, I would like to emphasize the remaining questions. First, is clearly CT the best technique for assessment of peripancreatic collections? In my opinion, clearly not. The place for MRI assessment has not been widely discussed in the 2012 Atlanta classification, and in particular, assessment of the ducts should appear in a new severity score. It's not the case today, but clearly it will be discussed for the next years. Maybe second question, which is a daily questions quite difficult. Are we really able to follow the rules? In particular, are we able to wait until 72 hours before performing the first CT? I perfectly know that in the era, most physicians will say, okay, it's probably acute pancreatitis, but are you sure that it will be not ischemic condition or mesenteric ischemia or something that needs urgent CT? So I know that in my own department, that rule is not respected every time. So I don't have the good way to resolve that problem, but I put the question on the table. Maybe we can discuss that point. So to conclude, the Revis classification of acute pancreatitis has identified two phases of the disease, an early during the first week and a late phase after the first week. There are three grades of severity. Mild acute pancreatitis is the most common form, has no organ failure, local or systemic complication, and usually will resolve in the first week. The second grade, moderately severe acute pancreatitis, is defined by the presence of transient organ failure, local complications, or exacerbation of comorbid disease. And severe acute pancreatitis is defined by persistent organ failure, more than 48 hours. And finally, for local complication, remember to use only those four terms: APFC, peripancreatic fluid collections for the first 4 weeks in case of interstitial edematous pancreatitis, acute necrotic collection in the first 4 weeks of pancreatic necrotizing pancreatitis, pseudocyst in case of interstitial edematous pancreatitis after 4 weeks, and walled-off necrosis after 4 weeks in case of necrotizing pancreatitis. All those collections may be sterile or become infected. Thank you for your attention.